Welcome to the Equine Vet Connect podcast. I'm your host, Dan Carter. I'm a veterinarian and a farrier. The goal of this podcast is to educate horse people, break things down, bust myths, and keep it real. Speaking of breaking things down, here's my legal disclaimer to keep my attorney and insurance company happy. While I am a vet, I may not be your vet. Contact them before trying anything you hear on this podcast. Remember, just because you watched it on YouTube or heard it on a podcast does not mean you can do it. Please use common sense. All right, welcome back to the Equine Vet Connect podcast here at Countryside Equine Hospital. I got Dr. Tori Martin with me in the studio today. We're getting into round 2 of Navicular. We had a big discussion. We talked about navicular is not navicular. Like, you got to dig a little bit more. We kind of went through getting it diagnosed and finding out the structural issues. And then we kind of left everybody hanging, right?
A little bit.
Yeah, we didn't tell them what to do once you got it.
No, not really.
So if you didn't listen to that episode, make sure you go back and listen to that episode before you dive into this one. We'll do a little brief, quick overview. So let's talk a little bit about, navicular is not what it was 20 years ago.
Right. So it's really a syndrome that's encompassing a bunch of different pathologies that are in the same region on the limb of the horse around that navicular bone.
Yeah, we've got, and like we talked about in the last podcast, the actual bone pathology is a very small segment of what this is. And that's why a lot of times, when we're working these cases up, we can't just stop at a radiograph.
Right.
Can't just stop it. Even if you see those pathologic changes, you see those degenerative changes, you see the, did y'all learn about lollipops? That's what we called it when I was in vet school.
Yeah.
Oh, look, these lollipops.
Yep.
It's a sign. It's something we see on X-rays, and they literally look like little lollipops coming off the or within the navicular bone. So you can see those. You can see cysts, but you can't stop there.
Right.
And so ultrasound's a great technique for looking at some of it. MRI is the gold standard.
Gold standard all the time.
Yep. And I'm a big fan of. I like getting the MRI on these horses. It's been a chronic issue. Let's find out what we're dealing with so we can get aggressive on the treatment and treat correctly.
Right.
You're going to spend way more, and that's one thing I want to talk about. We're going to spend a lot more in treatment throwing stuff at this to see what sticks.
Right.
Than if we just went and got the answer.
Right.
And I think that's it's a very important thing for people to understand.
Now, and kind of going into that from I'm just going to ask your opinion and your standpoint. Bursoscopy, when you actually go into the bursa, has diagnostic potential and treatment potential. So do you ever feel that it's fair to just say, let's lay it down and go in the bursa without the MRI first, since you're going and looking at it with your own eyes through a camera?
I'm going to say no.
Okay.
All right, and here's why. Bursoscopy is still limiting. All right, we can see what's in that bursa.
Right.
We can still get no idea about any kind of underlying bone pathology.
That's fair.
And we can't look within the deep flexor tendon.
That's also fair.
We also can't see the insertion of that deep flexor tendon. And to me, the insertional, so this is where the deep flexor comes down the leg and goes into the coffin bone. It's called the semilunar crest down there where it inserts. And those are probably the most challenging of pathologies to treat, which kind of makes sense.
Because of how inaccessible it is.
How inaccessible it is, and then if you think about anytime we have an injury that involves the insertion of a tendon or a ligament into bone, those are usually your most painful and the most difficult to treat because you're not just treating soft tissue structure.
Bone edema, all that.
You're also treating bone problems.
Yeah.
So I do think the MRI is still the gold standard.
Right.
Now, you can get a little more detail out of a bursoscopy. I'm a big fan of bursoscopy in certain cases. But I'll let the MRI guide that treatment.
That's right.
Well, if we're on bursoscopy, let's talk a little bit about what that is, since we've already been there. So you've been a part of some of these, is that correct?
Yeah. Back when I was in Texas, we did quite a few of them. And essentially what we're doing is we're taking a scope, I don't know if you've done a podcast on arthroscopy, but
I haven't actually.
Okay,
I should probably do that.
We talked about OCD, so maybe we should do an arthroscopy.
Yeah, we should talk about arthroscopy.
So you're basically taking a camera through tiny little portals that we make and actually going directly into that bursa. And so you're actually able to evaluate part of the deep digital flexor while you're down there. You're able to look at like the flexor cortex, things of that nature that are all within that region. If there's adhesions that you found on MRI, that's usually a way that we can access those and see kind of the extent of the inflammation in that bursa as well.
It's kind of a cool thing. I remember the first arthroscopy course I went to, they were actually just starting to teach this technique. And I remember realizing this is not the easiest. Like, you have very narrow margins. Like, it's all about the approach.
Right.
If you don't get that approach correct, it's not the easiest thing to see, but it is extremely powerful in treatment.
Right.
You're right on adhesions. Adhesions where you get a fibrous structure that goes from, most of the time it's from the tendon to the bursa.
Right.
And when it adheres, it gets very strong, limits the range of motion. Every time we pull on that adhesion, the horse experiences pain. And so being able to clean those up, I think, is a really valid tool. And we're going to talk about, when we get into some of the other treatments, even if we go in and do the buroscopy, there's things we've got to do post-op that are really critical for getting this to heal. Everything from the treatment to the rehabs.
Yeah, because when you think about surgery, like for a colic surgery example, you can get adhesions secondary to going in there and doing surgery. So the follow-up's really important because we don't want those to come back just because we've gone in there and disrupted as well.
You know, we've talked about this before on the podcast. Horses are really good at making fibrin. And fibrin's what forms adhesions.
Yeah.
I mean, they like to make an adhesion. I don't know what it is about
It's great for a wound.
It's great. However.
But some cases, it's not ideal.
So getting those adhesions cleaned up, we talked about that. We'll find those on MRI, and it's getting those cleaned up. We used to try, I remember before we were doing buroscopy, we used to do high-pressure HA. And you would literally put a needle. You'd put a needle in this bursa.
Wow.
And you would sit there with these tubes of HA, and I mean, you're just pressurizing the heck out of this bursa. I
guess you're more likely to bust the adhesions before you bust the bursa.
Well, and that was the
theory.
thought, is we'd break these adhesions down.
Yeah.
I can tell you it does not. It doesn't work. The horses get kind of painful afterwards, and
I imagine that pressure's not very comfortable.
It's not, and we didn't have a lot of success with it. It was a very short-lived technique.
Would you also be applying any kind of anti-inflammatory along with your age? Okay, I was thinking you'd have to.
No, and their block, we use a long-acting block. We try to get them about 6 to 8 hours with some bupivacaine, and there's a lot of NSAID usage afterwards. And there was a radiologist that was really pushing for the technique, and I did it 3 or 4 times, and I was pretty unsuccessful, and I noticed that that technique just sort of faded off into the distance. So.
Yeah, I think we should stick with putting the scope in there for those adhesions.
Get the scope in. And I'll tell you, where I really discovered buroscopy helping the most is a lot of times when we have these tendon tears, we'll actually get fibrillations, which is where the tendon's it's diseased and you have fibers on the surface of it that have broken.
It makes me think of like an old sweater that you start to just get little frays everywhere.
Yeah, a little frays in there. And then you can actually get, because at that level, the tendon fibers, I'm fixing to over-nerd this, so y'all bear with me, I can't help it. We're going down, we've got these normal type 1 collagen fibers.
That all line up. Exactly how they're supposed to.
And then when we get to that navicular bone, it's what they call a fibrocartilaginous scutum. And scutum is one of my favorite words in vet med.
You do kind of like that word, don't
I love that word. It's a great word. And what will happen is if these tears are near that bursa and it tears through, you'll actually get prolapse of this diseased tissue into that bursa. You can actually see it. It'll look like a split inside that scutum. And it's like this firm goo that is pushed out into the bursa. And what we've seen is if we don't clean that up, these horses don't get better.
Right.
And I think that's one of the biggest failures. Before we started doing buroscopy, before we started being able to clean that up, that was one of the biggest issues that caused a lot of failure in treatment, was not getting. And if you think about it, and I think this is a very simplistic way to think, but it's a very real way. When you have a tendon injury or a ligament injury, you essentially have a wound.
Yeah.
And
It's an internal wound.
It's an internal wound. And if that wound, if you have a wound on the external, one of the first things we do is debride the wound. And even throughout wound healing, we're always, there's a lot of times that we're constantly debriding these wounds. And so I think it's important to remember, like, don't overthink it being a tendon or a ligament. It's a wound. It's an internal wound.
Right.
So we got to debride those.
Yeah, unfortunately, with it being internal, at least in my minimal experience in a couple of years in practice, but when we go in and we do something arthroscopically, internally, bursoscopy, things of that nature, and we do a good job debriding it, we don't usually have to go back in and do that again. The body does a really good job from there.
Right.
Whereas some of our external wounds, like you mentioned, we have to go back through, and now we're granulating too much, so we take some off. But like the internal wounds actually tend to respond to one properly done treatment in terms of the debridement side of things.
They do really well, and I think that's getting in there and debriding that tissue. Like I said, I haven't had to go back in a second time. Getting that out of there, and this is either it's where the tissue's torn and prolapsed in, or it's proliferative tissue.
Right.
You know, it's almost, they can get this proliferative tissue secondary to an injury, and it's the body trying to heal it, but it's not steering it back to the other part.
It's not organized.
Right, it's just growing off the end of it. So we take these really cool, it's called a motorized resector. And it is the coolest thing to watch work, because this thing has a vacuum to it, and it's basically chews up this tissue and then vacuums it out.
Yeah, we always shaver.
Shaver,
The little
yes.
shaver. That's what we call it.
And it's so much fun to get in there and use. I'm not gonna lie.
I'm literally hearing the noise of it going while you're talking. Yeah, while you're talking about it.
Yeah, it's a fun little tool, and it's been a huge advancement.
Right.
In treating these. And so a lot of times after we get the MRI back, if we have this, we're like, hey, we hate it. We need to do a second surgery, and we need to go in and clean this up. But it makes, I can tell you, I have far more success after doing buroscopy and cleaning these up than I did before.
Yeah.
It's no different than, we'll do a podcast on this, but 10X is the way we used to debride some of these tendons and ligaments.
That's even newer too.
Much newer. Great technique. I use it a lot, and it has been a game changer in these injuries. And I feel like that's the way buroscopy's been. It's been a game changer.
Oh yeah.
The other thing we'll do on these, there's actually a veterinarian out in Texas who kind of pioneered it. But when we look at cyst, navicular cyst, so no different than bone cyst in a pastern, bone cyst in a stifle, we drill a lot of those. Destroy that cystic lining, and it fills back in with bone. And there's been a veterinarian out in Texas that's kind of pioneered this, Dr. Brock, and he's been actually drilling these cysts
Really?
as well. Yeah.
Okay. I have not been involved with drilling in the navicular cyst.
I've talked to Bo, and Bo is his daughter went on and became Bo was like an unboarded surgeon, but I'd let him do surgery on me.
Yeah.
And then his daughter went on and became boarded, and they've kind of worked together to pioneer this technique of drilling these cysts.
Cool.
And because before, that was a lesion that we couldn't do anything with. And they're having pretty decent success. I've looked at some of the papers they've published, and it's showing a lot of promise.
Yeah.
So we'll also go in there, and it's done arthroscopically through a small portal, tiny little drill the cyst, clean out the bursa, and these horses are doing well.
Okay.
And that was there's so many cysts in the bursa. There was or in a cyst in the navicular bone. There just wasn't anything we could do for them.
Right.
I mean, it was, I don't have any options. Well, Bo's created an option.
That's awesome.
So, buroscopy, I'm for it in the right cases.
I've seen a lot of good success with it.
So, let's get into more of the mainstays and things we typically use. Let's talk about the simplest. Some of these horses just have a navicular bursitis. The bursa is really inflamed.
Right.
And a lot of times we'll actually try this as a first line before we end up going to the MRI.
Mm-hmm.
We'll actually inject the navicular bursa.
Mm-hmm.
You done many of those?
More. I've been involved with a lot of them. Personally, I haven't done a lot of them yet, but
it's a pretty cool technique. We started out, and this typically involves a steroid and hyaluronic acid to quiet down the bursa. So a bursitis, the bursa is just really inflamed.
Right.
And we'll put a steroid and an HA in there to calm it down.
Right.
The original technique, I don't even know if they teach. I don't know what they teach anymore. I should look into this. You would X-ray guided.
Yes.
Before that, they were doing this blind. And I can remember I was talking to an older vet, and he said digital X-ray really increased our success rate on navicular bursitis. Because if you think about it, if you didn't have digital X-ray, because what you're doing is you're passing a needle through the back of the foot, you're watching it on an X-ray machine and guiding it into that bursa.
Right.
Well, back when you had plain film, you'd have to pass the needle, take the X-ray, run to the processing room, process this, come back, are you there or not? You're talking about 3 to 5 minutes every time you change the needle angle.
And you're asking a horse to stand still.
And they got to stand still. So needless to say, in the field, it was a blind stick. And he said, I think the reason we got this started working better was we were actually injecting the bursa more often.
Instead of intrafoot.
Yeah. So, yeah, the digital X-ray, because we can pop it up, it takes about 8 seconds for the image to pop up, but you got it in through the back of the foot. And then probably about 8 years ago, we switched over to the ultrasound technique. It's a real-time image. You actually identify the bursa. You pass the needle under ultrasound guidance into the navicular bursa.
I have not ever seen it done ultrasound guided.
Oh, you will never do it any
only
other
done
way.
radiographic.
When you do it ultrasound guided, you avoid the deep flexor tendon. You're not putting that small hole through there. It's actually really easy to do.
I've seen people take a side approach to avoid, but it still was always X-ray guided.
You do it ultrasound guided. It's faster. It's better for the horse. It's really easy.
I can imagine the real time is probably beneficial.
Yeah, and when I learned to do it, I literally had the paper in my hand. And I was like, well, I can find that structure because I'd ultrasounded a bunch of them, and then I could hit anything. If I could see it on ultrasound, I could hit it with a needle.
Yeah.
So it's an easy technique for me to learn. It's a little challenging at first.
You'll have to show me.
Yeah, if you're going straight into this, it can be challenging, right? Because if you haven't done a lot of ultrasound guided injections or you haven't scanned a lot of bursas, you're having to try to learn two things at once.
Yeah.
But it's a great technique. You actually come in from the side and you go behind the
Yeah.
deep flexor tendon into the bursa. It's a really great technique. Use it a lot. In fact, it's the only. I haven't done it X-ray guided, and I bet it's been 5 or 6 years.
You'll definitely have to show me that one.
It's a great
Even
technique.
if I'm not here that day, I
Yeah.
expect to be getting a phone call. I got some bursas to inject. I'll scurry on over.
It's really cool, really simple to do. Once you've seen it done, it's really easy. So, regular steroid and HA into a bursa if we're dealing with a straightforward bursitis.
Yeah.
Then we get into my favorite thing on planet Earth. I love regenerative medicine. This is where we get the reports back. We've got lesions in the deep flexor tendons, collateral sesamoidean ligament, the impar ligament, distal digital annular ligament, which is one that wraps around the deep flexor at that level. This is where we jump into regeneratives, and there's a lot of them. There's IRAP, there's PRP, Renovo, Regeniflex, Shockwave.
Yeah, I
What
feel
are
like a lot of
stem
people
cells?
like PRP and stuff like this.
Yeah, and I've kind of moved away from PRP, and I'm more on the amnion products.
Okay.
It has more to do with PRP. When we pull this blood, we kind of hope there's enough growth factors.
Right.
And with the amnion products, we know there's enough because some nerd somewhere figured out how much is in there. So I like that. That's just a personal preference.
Yeah.
Nothing wrong with PRP. I just prefer the consistency behind the amnions. So we did a podcast on Renovo. If you want to look more into that, that'd be a great podcast to listen to. But it's really the same thing, right?
Mm-hmm.
Same techniques to get it in there, but
Just a different product.
Different product. We're focusing on that regenerative aspect.
Right.
And I'm a really big fan of this after. If we have fibrillation of a deep flexor, we have have adhesions, we have that prolapse tissue. That's after we've debrided it, that's a really great time to go use those.
I've also seen people after surgery use stem cells.
Yes.
And I've seen people even use stem cells in a regional capacity.
Yes.
And it seemed to be beneficial in the cases I've seen that used on.
No, it's a great technique. In some of these cases, I will do that. There's been a lot of them we have to set up where we harvest the stem cells, have those sent up to the lab, get those processed, and go in and do the surgery. And about the time they're ready to have it done, we get our stem cells back.
Yeah, we did a lot of taking for the stem cell while they were under for the bursoscopy. And then at their 2 week, or usually we could get them back within those 2 week period. So by their 2 week, sutures are coming out, we're wanting to inject, we've got stem cells, and obviously you have, as much as you get, they stay, you're able to keep them and use them later as well. So.
No, stem cells are great, and you brought up the regional, and that's where we put a tourniquet around the fetlock and put them into one of the vessels in the foot, and then they'll actually migrate from the vessel to the injured site.
Right.
And that's the cool thing about stem cells. Stem cells, they're like on a hunt, and that's
have a mission.
Yes, they're headed to that site. And there's some ins and outs on stem cell usage, and the big one is when to use them. If you use them too early, you've got a glorified anti-inflammatory.
Right.
A very expensive anti-inflammatory. You're getting very little regeneration out of this. So timing's everything, which is why we don't do them during surgery.
Right. Yeah, that's why I think that we would harvest them at surgery and go from there.
And using those as a regional is great because we didn't have the risk of going into that bursa. And they work. If you're using stem cells, they work pretty much. I think there's only been one study on this, but you've got about the same results using them as a regional as you do
putting them right in.
Right in.
Yeah.
So we seldom inject the actual tendon with stem cells at that level because it's just not a great spot to inject.
Well, in stem cells, traditionally, at least in what I've seen, you have an even more decreased likelihood of reacting. Like in some products, again, it's not necessarily a high risk, but occasionally you get a flare of some kind, especially if you're going into a joint or bursa structure. But I haven't seen that with stem cells. I haven't seen a horse with their own stem cells that's flared real bad.
I haven't either. You will see, when I've used them in other sites, you'll see some puffiness or it's like a little bit of swelling near the injection site or where the injury was. And that's just due to the increased metabolic activity in that area. And a byproduct of metabolism is water.
Right.
And so we'll see that. But I have not had, really haven't had a downside to stem cells. And I've used a few hundred of them.
Yeah.
We can actually get some off-the-shelf stem cells.
Okay.
So UT's got them now. Used to be a lab in Texas we could get them from. And the crazy part about that is now you cannot go into a synovial structure with them.
Right.
You can get a flare there, and they've actually shown some negative impacts of.
But as a regional,
another horse's stem cells work just as good as your horse's stem cells. And so it's pretty cool. Like I said, if we're going into a joint,
you got to use your own.
You got to use your own.
Yeah.
They've actually shown some negative effects from using other horses in a joint, which we didn't know about for a few years.
We live and we learn.
And we learn.
That's how we get better.
Yeah, it's kind of like the Wild West out here sometimes. But yeah, stem cells post-op, or even if we don't need debridement, using those stem cells to treat is a great technique as well.
Yeah.
So let's talk a little bit about treating bone pathology. This is
I feel like this is your opportunity to get on a really big soapbox.
It has the potential.
Should I say the word that everybody?
Let's go with bisphosphonates.
Yeah, that's the word.
All right.
Controversial in some capacity.
Well, and let's talk a little bit about bisphosphonates.
Should probably talk about how they work.
Yes. So there's three main ones. Well, one of them we don't really have anymore.
Tildren.
That was the OG.
Telludronate.
Yep, that was the first one. That was Gen 1.
Mm-hmm.
We'd give it as an IV drip. We'd use it as a regional limb. There's a lot of different techniques with it, but I don't even know if you can get it anymore.
I mean, at one point it was FDA approved, but I don't know if we have access.
It's still FDA approved, but I don't think they're making it anymore.
I think in Europe, maybe they're still using it, but we're not getting it here.
Well, when I first started with Tildren, now I'm showing my age, it's like 12, 13 years ago, even 15 years ago, we would have to get these special permits to import it out of Europe. And I remember there was one distributor that we could buy from out of the UK, and we'd get it shipped over here from the UK. We used to use a lot of it.
Yeah.
And then there's Osphos.
Which is clodronate.
Correct. It's kind of your Gen 2.
Mm-hmm.
And we won't get into it in this episode, but they're separate by how they work. That's a systemic treatment. It's given IM.
Mm-hmm.
It goes throughout the entire body. The next one we talk about is, most people know as reclassed.
Zoledronic acid.
Yeah, zoledronic acid. That one's pretty cool because I do like the fact, this is off-label, but we do use it as a regional.
That's honestly the only way that I've seen it used, and have seen it used quite a bit in that capacity.
Mm-hmm. If I'm going to grab one of these, that's the one I'm going to grab, because we're going to talk about some of the downsides to these bisphosphonates as well.
Right.
But the only product on the market labeled for treatment of navicular disease is Osphos. Well, and Tildren.
And Tildren
But we can't get
yeah.
Tildren. Let's dig in a little bit about how these work, because I know there's going to be a lot of questions on it. They are an osteoclastic inhibitor.
So basically they go in, they attach to the bone, and they basically engulf the osteoclasts. And from what I've looked into, they somehow trigger apoptosis of those osteoclasts.
Well, it inhibits that bisphosphonase enzyme.
Yeah.
And that's what shuts them down. So apoptosis is, if you remember your high school biology, programmed cell death. It just kills the cell. But yeah, it's when this stuff goes in, it distributes to bone, and it is in that bone. And the only way out of that bone, it doesn't leach out. The only way out of that bone is for an osteoclast to come along.
Well, and we should also probably mention osteoclasts come in and essentially chew up bone, and then your osteoblasts come in and rebuild that bone.
Osteoclasts are kind of like the motorized resector of the body.
Yes.
They clean up all the junk. And if you want to talk, and that's something important when we're talking about this, is like if you have damage to the bone, it's no different than having damage to your house, right? You can't rebuild this house until you clean up the damage.
Right.
So the osteoclast is critical for cleaning up the job site. They got to do the demo work.
Right.
If you don't demo, you can't build back. And so when you shut off that osteoclast, you're not getting rebuilding a bone.
Right.
And I think that's my concern.
That's where there's some risk with it.
Yes, because bone is constantly remodeling.
Right.
And that can be a bad thing.
Well, yeah, because I mean, if we think about it, and I think this is probably some of the theory as to why we like to use it in navicular, why it's marketed for navicular, is that we talked about the lollipops, but we also can get a lot of sclerosis of that bone. And so when we're getting like an excessive amount of sclerosis, then I can make the argument for, hey, we need to stop building up this bone down here. We sometimes get little proliferations. So I can see making the argument for let's slow down that process a little bit and try to help the bone in that capacity.
100%, because because other things we see when I'll think about grabbing one of these is when the MRI comes back and it says navicular bone edema, because where that edema is coming from is usually increased metabolic activity
Right, because you talked about the water. And, yeah.
Right. And so by stopping this process, we can work on that navicular bone edema. So that's a case where we have a pathologic condition that necessitates this medication.
I think the little, I guess, guardian watching over me, angel watching over me with OSPOS is we're sending this everywhere in the body with OSPOS, and that's what gives me a little bit of hold up, because we don't really, unless we've MRI'd the whole horse, which we can't and won't do. What happens when there's something else going on in our other bones, and we prevent a healthy bone remodeling process?
That's my big concern, is when we're dealing with normal physiologic bone development. So when you exercise, your bones get stronger.
Yes. Is that Wolff's Law, I think?
Yes.
Wolff's Law. Yeah.
Wolff's Law. So when you exercise, your bones have to get stronger. Well, the osteoclast is very important for that.
Right.
And so when we have, and again, it's going to distribute throughout the entire body. And so it's going to be in parts of these bone that we need no more remodeling to happen, but it no longer can, because we've blocked it. And so I think that's my big concern. But I don't want to scare everybody from never using it.
Right.
But you have to, what I always say is, anytime we're going to treat anything, I don't care what it is, we always have to ask the question, at what cost? At what cost?
Right.
And so I think you have to look at a lot of things. So I have when we look at where these were originally developed, and it was for women with osteoporosis. So these are older women, and they're not, there's an actual disease process causing their bones to degrade.
They're breaking down more than they're building up.
Right.
Yeah.
So we have a pathology we need to treat, and the risk is, okay, we may make the bone more brittle. We're just doing that anyway. So at that point, the risk outweighs, or the reward outweighs the risk.
Right.
And with some of these navicular cases, I think it's the same thing. Our reward outweighs the risk.
Right.
But we need to be careful about when we give it.
For sure.
So
I've also seen some horses that have had it that we've needed to break down the dose and give it on like half of it, and then a couple of days later the other half, just because of some systemic malaise after the injection. So that's something to consider, as well as certain horses are more sensitive to it than others.
Right. And I think that's where, like we talked about the zoledronic acid, the reclass, I think that's where it's gained in popularity. We do it as a regional, and we isolate the area we want to keep it. So our thought process is, it's a lower dosage. We're trying to focus the absorption of it in the bone that we need. We're hoping to treat, because when we take the tourniquet off, whatever's left in circulation, it goes.
Yeah.
But it's most of the time we're dealing with regionals, we're using like a tenth of the dose of a systemic.
Of what a systemic dose would be, yeah.
I don't know where that number came from, but that seemed to be the magic number that some nerd somewhere came up with in antibiotics. And
I mean, if you're seeing the benefit and you're not seeing side effects, might as well stick with it.
Yeah. So I think that's why in those cases, that's why I reach for the reclassed.
Yeah.
Is trying to minimize my systemic effects. So, which is really a goal of any medication. If we can minimize systemic effects, and again, decrease that risk, still get the reward with a decreased risk, that's a great place to be.
Well, and to your point, the bone edema, let's say we've got something going on in our coffin bone, we can do the same thing.
Absolutely.
So it's not just to say that because we're talking about it with navicular bone pathology is, I mean, I've seen it do some good stuff for coffin bone pathology as well.
Well, and I think that's what I really want people to understand is, yes, it has side effects, but it also has a place.
Absolutely.
And this is where understanding what is going on, where the issues are, and knowing as much as you can allows you to make the best decision you can instead of just willy-nilly throwing it out there. I personally don't use a lot. I have to have a reason to use it. But that's just my...
So let's just throw one other thing into the mix, because I know that there's probably a lot of people listening. A lot of people that are listening to this may have had horses that have been diagnosed with Navicular Syndrome in some capacity. What is your thought on injection of the coffin joint as a very first line? Because I've seen that a lot, and some horses respond very well to it in terms of their clinical presentation. Maybe these are horses potentially that were not on the page of getting into an MRI just yet, and we're at a more try it and see, which I know is not your MO, but thoughts on the proximity of the coffin joint and benefit from those injections?
We know in a certain number of horses that coffin joint will communicate with the bursa.
Right.
And even the ones that doesn't, you're talking about two thin synovial membranes. And so you can get diffusion of the medication across.
Right.
So there is some validity to it. If I'm suspect of the bursa, I can, so I inject the bursa.
Right.
And a lot of times I'll do both of them, a coffin joint and a bursa. But yeah, injecting the coffin joint is not a wrong place to start.
Yeah.
A lot of people prefer that route because if you're learning, it's much easier to inject the coffin joint than it is the bursa.
Oh, for sure. As someone that's still young in my career, I've injected plenty of coffins, but that doesn't mean I've injected a bunch of bursas yet.
Right.
So if I can start there, but to your point, with this ultrasound guided,
it's no more difficult than
Exactly.
doing. At this point in my career, it's no different than doing a coffin joint. It's really not difficult. But a lot of people, if you're not, I'm doing ultrasound guided injections on a daily basis, so it's a very easy technique for me to do.
And to some capacity, you could make the argument that a coffin injection is a bit less invasive. I mean, yes, if you're using ultrasound to avoid, but much longer needle, more structures that are around.
Yeah, if you're using ultrasound, I don't think there's any more risk to it. The risk when we were doing and this was important because when we would do the older technique, this is back when MRI first came out, we were passing the needles through the deep flexor tendon. And it wasn't like cutting fibers. The way the type of needle we use actually goes between the fibers. We would see this on MRI. We'd see this artifact. And the radiologist had to read around that artifact. And he would take... Usually they were hoping for you to be 30 to 45 days post-injection before they
That's
MR'd.
an interesting point. I didn't know that.
Yeah, it would show up because I would get the call, hey, did this horse, I'd get a call from a radiologist, did you inject the bursa on this horse? Like, yeah, sorry, I forgot to tell you that. Okay, well, because they were, instead of reading that out as an injury, they would read it out as a artifact from injection.
Yeah, gotcha.
But it could be a little...
It could distort things a bit.
It could distort things.
Yeah.
And that's probably the main reason, or not the main, but that's one of the other reasons I switched over to the ultrasound technique, was because I avoided that deep flexor completely.
Right.
So if I did have to go to MRI, I didn't have that artifact to contend with. But yeah, injecting the coffin joint, great first line. Some horses, that's the way we've treated them for a variety of reasons. We've gone through the coffin joint, but bursa's best. The coffin joint, like I said, I think it's 60% of the horses that communicate.
Something like that.
And it's kind of weird. Like, I don't know what they teach anymore, but I remember like when I was in school, they're like, well, usually the coffin joint communicates with the bursa. So if you treat the bursa, it'll flow, or treat the coffin joint, it'll go into the bursa, but not really the other way around. And I never understood that. I don't know if we were thinking from a gravity perspective. I don't know.
I kind of want to be like, make that make sense, but
Yeah, that's what I run into, is make that
Yeah.
make sense. But I just...
Well, and would you? I mean, I guess if we're expecting it to, have some diffusion into that bursa, if we're dealing with a bursitis, it should help. In terms of the potential bone pathology, I mean, your coffin joint and where it sits in relation to your navicular bone, like it could potentially have some benefit there as well.
Yeah.
So.
I mean, I like to kill mosquitoes with sledgehammers, so if I'm treating a bursa,
You're going to the bursa.
I'm treating both of them. I'm going to hit the coffin joint and the
Okay.
bursa. 90% of the time, if I'm putting something into the bursa, I'm doing the coffin joint as well. If this is what's going to solve the problem, let's get the problem solved.
Yeah.
I don't like messing around. So, and a little bit on shoeing.
Yeah, I was going to say the last
Yes.
Because navicular syndrome, just like it encompasses a bunch of different pathologies, I feel like we do end up taking a very multimodal approach.
You have to.
So, shoeing.
Shoeing, yes. When I'm talking to farriers and we're doing clinics a lot of times with farriers, a lot of them want to talk about laminitis, and I'm like, yeah, you're going to see 1 or 2 laminitic horses a year. But I ask, like, how many of y'all have got 10 or 20 horses in your farrier practice have some type of navicular pathology? Mm-hmm. And I mean, everybody's hand goes up.
Right.
I was like, why don't we talk about that?
Right.
Because that's something you're dealing with every day. This is chronic management. Laminitis, yeah, we'll talk about that if you want to, but that's a whole different can of worms. So there is a huge array of approaches to navicular. And the reason, I always say, anytime we have multiple approaches to something,
it's because we don't know the best way to fix it.
Yeah, that means none of them work. And so, and again, what does help is having that clear diagnosis to know exactly what we're treating. Is this because the treatment for a bone pathology is not great for a tendon. Mm-hmm. Treatment for a tendon isn't good for bone pathology. And a lot of it depends on what we have.
Well, yeah, and it just goes to show that if shoe A and that package worked for one horse, but it didn't for 3 others, and then shoe B, that package worked for a different horse, well, probably because they had a different pathology that was diagnosed as navicular.
Well, and the one thing I want to say from a shoeing perspective, a lot of times there's a wedge involved.
Yeah.
People want some type of wedge. I'm not the biggest wedge guy out
and
there.
The theory is the pressure on the deep flexor.
Right, but I think we got to remember, I think it's either 14 or 17 degrees of wedge
to
before
actually
you
release pressure.
Yeah. But the biggest thing I'd say is if you're going to use a wedge, you have to have some type of frog support. Mm-hmm. Whether that's a frog support pad, whether it's a wedge with a heart bar, whether it is a pouring pad equipack in the bottom of this foot, if it's a heel plate with impression material, you have to have some semblance of frog support if you're going to use a wedge. If not, the foot will sink down through that shoe. So you're wedging it up, but yes, the hoof wall is wedged up, but the entire internal structure of the foot just prolapses down through the shoe. And that's the biggest thing I've seen with horses that have wedges on for navicular and them not improving. It's like, well, that's because your whole foot's prolapsed down through this shoe.
Yeah.
So if you're going to use a wedge, you have to use some kind of frog support. You have to.
That makes sense.
And it's like, if people get nothing else out of this podcast, that one thing, because I'm tired of seeing wedges without frog support.
Yeah.
Because all you're doing is picking up the frog more off the ground. It's going to seek the ground. Mm-hmm. It's going to prolapse through there. There are some feet that can tolerate it that don't do that, but those feet are few and far between. So as a general rule, if you're going to put a wedge on, you've got to have some type of frog support.
And the feet that can tolerate that are not going to have a deficit of having frog support.
Correct.
So risk reward.
They're usually not the ones with the pathology.
Yeah.
So, yeah, like if you're going to use a wedge, you've got to have a pouring pad, you've got to have a heart bar, you've got to have impression material with a heel plate, you've got to have a frog support pad. An egg bar is not frog support. A straight bar is not frog support. You have to have, if you're going to use a bar, it has to be a heart bar of some kind if you're going to get frog support.
Okay.
So that's one of the biggest things I've seen. Breakover. Everybody talks about reducing breakover and decreasing toe length. We're not even going to get into that on this podcast because I will. I got some friends of mine coming in, some farriers coming in, and we will dive off into breakover.
Yeah, we already had that lesson a couple weeks ago.
Yes.
I think I could wait a few more weeks before having it again.
I have very strong opinions about this. Very strong. So, but yeah, shoeing, the biggest thing is I really love working with the farriers on this. It's one of my favorite things to talk about because, like I said, everybody's got them in their practice.
Right.
So, I'd probably say the biggest thing when it comes to shoeing is having a good farrier. Having a good farrier that has skills and abilities and knowledge.
I think that would be said for most professions and
Yes.
most shoes.
and we'll work, and like I said, it's so variable based on, that's why we're not getting into, we'll do another episode with some farriers on shoeing these navicular horses, but trying to dive into all the different techniques is a lot, but there are shoeing changes that we need to make in a lot of these cases.
Yeah, and it may still not be a one size fits all. Like your point of like, if you're going to use a wedge, you have to have that support. Sure, in any wedge, you should have that support, but that doesn't mean that every navicular diagnosed horse is going to need that wedge with that support in that capacity.
And when it comes to shoeing these horses, the biggest thing I can tell you is patience, because we're going to we're very seldom do we hit this one on the first shot.
Yeah, I feel like you have to, and we have to do this as vets too, is you have to maintain a sense of adaptability.
Yes.
You've got to be malleable enough to flow with how the horse is responding to the treatment that you're providing. And by treatment on a farrier side is by the shoeing package they put on.
Right. So that's biggest thing I can tell you from shoeing. Two things: if you wedge, you have to use frog support. The other one is be patient with your vet and farrier when you're working through these shoeing changes, because it may take 3 or 4 adaptations, and we may hit it on the first shot. Great. I think most of the time we improve or we fail miserably. And if we improve, we still have to do some tweaking. If we fail miserably, guess what? It gives us a better understanding.
We
of what
know
we
to
do
go the
next time.
opposite direction.
Yeah, we know what kind of do next.
Yeah.
So bear with us as we work through that. So hopefully that all makes sense from a treatment perspective. We did our best to kind of cover the different modalities out there. Again, I think it goes back to that accurate diagnosis. What are we actually dealing with?
Yeah.
From a quote-unquote navicular perspective.
And it is, in generally speaking, unless it, like from a bone pathology standpoint more so than a soft tissue, it can be progressive in nature. So similar to an osteoarthritis, it's not necessarily something we can completely reverse everything that's gone on so far, but we keep working with that horse and doing what that horse needs to get them feeling better.
And this is one of the few times where I actually prefer having a soft tissue injury over bone pathology.
You can fix it.
Because the degenerative ones, they're degenerative.
Yeah.
We may slow it. We ain't fixing it.
Yeah.
So this is one of the few times where I would tell you to hope for soft tissue pathology over bone. So
yeah, you wouldn't think that you'd say that, but yeah, this is a case in which that would make sense.
That's what I'm gonna say. So hopefully that all makes sense. Thanks to everybody for tuning in today. Like I said, this is Navicular Part 2, so appreciate y'all listening. When in doubt, ask your vet. Talk to your vet about this. If you get this diagnosed, it's really important to have them on this conversation. And we appreciate everybody being here. Casey, thanks for editing all this. April, as always, thank you for filming all this and dealing with the technology aspect. Dr. Tori, thanks for being here today. From all of us here at Countryside, hope y'all have a great week. Take care.